Okay, good morning, everybody. We can start the second day of the Congress, and this morning the first session is focused on the pulmonary valve. Yesterday we started with the mitral one, we continued with the tricuspid one, and now we have the aortic one, the tricuspid one, and today we have the pulmonary valve. And again, I have, the profound privilege to present Bob Anderson, the anatomist, who will present the congenital pulmonary valve defects, the anatomy of the congenital pulmonary valve defects, and right ventricular outflow tract morphology lesions. It's pre-recorded. Please start the video.
So, ladies and gentlemen, to complete my presentations, we're now going to discuss the pulmonary valve. And as with all the other presentations I've given for you, we're going to use the arrangement of the normal valve, hopefully to understand what is going on when the valve is abnormal. And when talking about the pulmonary valve, what I'm going to be emphasizing is the influence of the infundibulum. And hopefully that will become clear to you as we go through the presentation. Because it is the location of the infundibulum that underscores the features of the valve when it is abnormal. But let's start off by looking at the normal pulmonary route. So here I've sectioned the heart to parallel the oblique subcostal echocardiographic cut. You will immediately recognize the central location of the aortic root, and that was the emphasis of our second presentation to you. But now, arising from the right ventricle, we see it's supporting the aortic root, but above a completely muscular infundibulum. And this is the feature that is going to underscore the anatomy of the pulmonary root. Distally, pulmonary root continues as the intrapericardial pulmonary trunk, but as with the aortic root, the pulmonary root is bounded proximally by the virtual basal ring. We create that by joining together the nadirs of the semilunar hinge points of the valvular leaflets, and it's limited distally by the sinutubular junction. So let's look at a little more detail of the pulmonary root, and we can see that particularly well when we open it out. So here we've spread open the pulmonary root. At the bottom of the screen, you're seeing the muscular infundibulum. To the top, we see the arterial wall of the pulmonary trunk. And there you see the semilunar hinges of one of the leaflets. And you'll immediately recognize that in the pulmonary trunk, as in the aortic root, we have three leaflets. There is one, the second one where I've outlined the semilunar hinge, and there is the third leaflet. But hopefully you will also recognize that unlike the arrangement in the aortic root, in the pulmonary root, all of the leaflets have myocardial support. We can see that much better if I show you an open pulmonary root where I have cut away those leaflets. And now we can see the hinges of the leaflets. And you see that all of the hinges cross the myocardial junction between the infundibulum and the arterial wall of the pulmonary trunk. So in the pulmonary root, we can call this the anatomic ventriculo-arterial junction. And it is a complete ring, having cut away the leaflets. You note that there are interleaflet triangles, as in the aortic root, and they extend from the anatomic ventriculo-arterial junction up to the sinutubular junction. But the feature of the pulmonary root is not only the sinutubular junction, but also the presence of these three myocardial crescents. And it is when we join together the nadirs of these three semilunar crescents that we are able to produce the virtual basal ring. As in the aortic root, I'm sure that this is what many of you echocardiographers will call the annulus, but as you will see, there is nothing there that is a true anatomic entity. It is a virtual basal ring. We can see that rather better if I build up the structure of the pulmonary root as we would see it in a transected situation. So we'll put in the anatomic ventriculo-arterial junction, and that is the union between the muscular infundibulum, the fibroelastic walls of the sinuses, and the pulmonary trunk. And now we'll put in the sinu-tubular junction. And then we'll mark in the location of one of the, we'll put in the hinges, the semilunar hinges of the leaflets of the pulmonary valve. And now we'll emphasize the fact that those hinges are semilunar. And you see that they cross that anatomic ventriculo-arterial junction. And that means that between the semilunar hinges, between the sinuses, we have arterial wall as part of the ventricle. It also means that proximal to the anatomic ventriculo-arterial junction, we have ventricular muscle within sinuses. We have that in the aortic root, but in the aortic root, the myocardial crescents were present only at the bases of the two sinuses that gave rise to the coronary arteries. In the pulmonary root, there is myocardium at the base of all three of the sinuses, and it is by joining together the bases of those myocardial crescents that we produce the virtual basal ring. So let's put all of this now together in terms of a three-dimensional entity. And you see that when we look at those semilunar hinges in 3 dimensions, they come together in the form of a crown. So if I'm going to talk about the structure of the pulmonary root, I would rather call it crown-like, because those semilunar hinges extend from the sinu-tubular junction to the virtual basal ring. There is another ring within the root, and that is the anatomic ventriculo-arterial junction. Which of these rings is the annulus? You pays your money, you takes your choice. But for me, the overall arrangement of the root is crown-like rather than ring-like, because there are far too many rings. But nonetheless, I'm sure many of you will still describe the virtual basal ring as the echocardiographic annulus. But remember, many surgeons consider the semilunar hinges as the surgical annulus. So we still do have problems with describing the annulus. What we should not forget, however, irrespective of how we talk about the annulus, we should remember that the aortic valve is forming the centerpiece of the heart, and that the pulmonary root is lifted away from the aortic valve by the freestanding infundibular sleeve. That is also important for the surgeon, because arising from the anterior interventricular artery is the first septal perforator. Now, you all know that oftentimes surgeons will remove the pulmonary root for use in the Ross procedure. And this is what it looks like in the dissected heart when we have cut away the freestanding subpulmonary infundibulum. And that shows you what the surgeon needs to take note of when performing the Ross procedure, the location of the first septal perforating artery. So how do we put all of that anatomy into the understanding of mechanisms of stenosis? Well, there are various ways that the pulmonary valve can become stenotic. Most frequently, there is commissural fusion, but on occasion, the stenosis is no more than dysplasia of the leaflets. And this can be linked with tethering at the sinu-tubular junction. But let's concentrate on commissural fusion, because it's an easy matter that to see when we have commissural fusion, the valve can no longer open to what we call the commissures, and we now know that the commissures are the peripheral attachments of the zones of apposition between the leaflets. So when we have commissural fusion, then the valvar orifice is obviously reduced in size. And typically in the pulmonary valve, we have uniform commissural fusion, giving us a pinhole central meatus. And we can see that beautifully by looking down on this stenotic pulmonary valve, in this instance, probably critical pulmonary stenosis. There you see the so-called commissures, the peripheral attachments of the zone of apposition, and you can see the marked tethering at the level of the commissures. But what I want to emphasize is the commissural fusion, giving us this central pinhole meatus, giving us the volcano appearance that is the characteristic of the stenotic pulmonary valve. And that again is the consequence of annular attachment of the leaflets. And again, I emphasize to you the annular paradox. Normal leaflets are attached in semilunar fashion, but the more obvious we find an annular attachment of the leaflets, the worse is the degree of valvar stenosis. And we see that particularly well in the setting of the pulmonary valve. We see it even better in so-called absent pulmonary valve syndrome. The term absent pulmonary valve is a misnomer because hardly ever are the valves completely absent. Usually they are rudimentary, but they are attached in annular fashion, and it is that annular attachment that makes the valve incompetent. And here we see a beautiful example where we have this annular attachment of the rudimentary leaflets at the junction between the infundibulum, the intrapericardial pulmonary trunk, which is dilated because of the valvar regurgitation. So in this instance, the valve can not only be stenotic, it can also be regurgitant. But of course, the pulmonary valve is likely to be abnormal in other situations. So I'm going to concentrate now on two particular arrangements. First of all, tetralogy, and then transposition. In tetralogy of Fallot, valvar stenosis makes the infundibular narrowing even worse. And that can be found when the valve itself is trisinuate and trifoliate, but usually in tetralogy of Fallot, the valve itself is functionally bicuspid. And that can be because the root itself is trisinuate, or because not only is the valve bifoliate, but the root is bisinuate. And as with the normal valve, the narrowing can be made much worse by dysplasia of the leaflets. So here is the situation where the valve is narrow but is relatively normal. And these beautiful pictures were made by my other good friend, Rohit Lumba from Chicago, and again by Diane Spicer from Florida. And they have opened the valve to take this beautiful picture. Again, you see the infundibulum, and we see 3 leaflets. There is no way, in fact, you would know that this was not a normal valve, but in fact, it is the pulmonary valve in the setting of tetralogy of Fallot. So on occasion, the valve can be relatively normal, but most usually it is not. So in this picture, again, from tetralogy of Fallot, the infundibulum, we see that there are 1, 2, 3 sinuses, but 2 leaflets. And that is because there is a raphe between 2 of the sinuses. And this is one of the arrangements that gives us the bicuspid valve that we find in 2/3 of examples of tetralogy of Fallot. And note again the vestigial interleaflet triangle. But on occasion, when we have the bicuspid valve in tetralogy of Fallot, again the infundibulum, now we see 1, 2 sinuses along with 1 and 2 leaflets, with 2 zones of apposition extending to the sinutubular junction, now without a raphe. So this is the bisinuate and bifoliate leaflet which we find in the setting of tetralogy. Sometimes, however, we have the arrangement where we have three sinuses with uniform commissurial fusion, giving us the volcano arrangement as we saw in that critically stenotic pulmonary valve, this time a critically stenotic pulmonary valve coexisting with tetralogy of Fallot. Here you see the arrangement where the leaflets are dysplastic, but in a bisinuate and bifoliate valve. And don't forget that in tetralogy of Fallot, as we see here, we can also have rudimentary formation of the leaflets, the so-called absent pulmonary valve syndrome, now with dilation of the pulmonary trunk. So to finish, we can also have abnormalities of the pulmonary valve with discordant ventricular arterial connections, and this emphasizes again the significance of the infundibulum. Because almost always, when the pulmonary valve is found in the setting of transposition, it lacks an infundibulum. It is in fibrous continuity with the mitral valve. And then the valve behaves as would the aortic valve in the setting of concordant ventricular arterial connections. So here is a beautiful example of a stenotic pulmonary valve in the setting of transposition. This beautiful picture again taken by Diane Spicer. So now in the setting of transposition, we find the aortic root anterior and right-sided, but look at this pulmonary root. Because here we have a trisinuated root, but a unifoliate pulmonary valve, replicating the situation I showed you in the so-called unicommissural and unicuspid aortic valve with concordant ventricular arterial connections. And as in that setting, the solitary zone of apposition that reaches the sinutubular junction is pointing towards the mitral valve. So hopefully, ladies and gentlemen, I have shown you that with all the valves, if we are to understand the malformations, first of all, we need to understand the normal anatomy. And that is just as important for the pulmonary valve as it was for the aortic, tricuspid, and mitral valves. As with the aortic valve, with the pulmonary valve, to understand the malformations, we need to distinguish between the leaflets and the sinuses. And don't forget the importance of that annular paradox, because perhaps the hardest part in all of this is understanding what is the annulus. Remember, the arterial valves have semilunar hinges. In the atrioventricular valves, it's very rare to find a complete annulus. So maybe we should forget the annulus and simply concentrate on describing the anatomy. So thank you for permitting me to be with you. As I say, I am so sorry I can't join you in person, but I hope that my presentations have helped you to understand the anatomy of the cardiac valves. Thank you so much.